Cardiovascular emergencies are the leading, or diseases, one of the leading cause of death in the adult population worldwide. And as AEMTs, you'll be called to a lot of calls involving these emergencies. But when everything in life, they always say prevention is better than cure. Therefore, instead of just responding to provide emergency medical care to persons with these emergencies, if we could help, or they could help themselves to prevent them, then we would be called to them less often. Therefore, a big thing for us, even as healthcare providers, is about being an advocate for our patients, and therefore we should be encouraging them, and even ourselves, as we look at the well-being of the healthcare provider, we need to be encouraging ourselves into how we can prevent these cardiovascular diseases. There are some factors that we call risk factors that makes us more prone for these cardiovascular diseases, and there are a set of risk factors that are modifiable or controllable, while there's a set that is not controllable. Risk factors that we cannot control as it relates to cardiovascular diseases are our age. As we get older, we are going to be more prone for these diseases, cardiovascular diseases, and other diseases also. The race that we are born in makes us more prone. The black race, African race, certain races are more prone. Our gender, male are more prone also for these cardiovascular diseases. Therefore, that there's not much we can do about those risk factors, but there are some that we can control and modify, and these are our eating habits, our diet, or the fact that we don't get enough exercise, fact that persons smoking makes you more prone for cardiovascular diseases, excessive consumption of alcohol. These are factors that we can control and should, as we look towards preventing cardiovascular diseases. But let's say we cannot prevent it, and what can we do to lessen the impact of it? This is where we are looking at these reducing cardiovascular deaths. How can these deaths be reduced? And we need to go back to a slide that we will come into later on, the chain of survival for an adult with a suspected cardiac arrest. What are the chain of survival? What are the chain of things that should happen? What's the link that should take place in order to give that person the best chance of survival from this cardiac arrest? And we should know that the first link in that chain is early recognition and activation of the emergency response system. If you do not recognize that a person is having a suspected heart attack, then the chances of them recovering has diminished from the beginning. And once you recognize it, you need to activate. The second link is once you have recognized it and activated the response system, then you must have early effective CPR. That is, in most cases, buying some time for that person until they can get the next link, which is early defibrillation. And all these three links in that chain is coming from layperson coming to the early intervention of EMS. The fourth link will be advanced care. Early advanced care is what's gonna help most persons when the basic care fails. And after you have been successful, if you have been successful in resuscitating that person, then the next link will be integrated post-arrest care. You get that person back, and if you're not careful in what you're doing, then they can go back into arrest. So reducing cardiovascular deaths is gonna come by better public awareness. And as AEMTs, you'll be called to play a role in that aspect also. So it's not only about going on our job, responding to the calls. We have to be mindful that we have that advocacy for our patient. We need to be making the public aware of these things that they can do to help. Also, you need to have early access to EMS. Again, we said the first link is recognizing the possibility of that cardiac arrest case and activating the EMS system. If that is not on its way, then that person's chance is gonna diminish as time goes by. And we say time is heart muster. You need to have increased numbers of laypersons training CPR. You need to have persons on the scene that can provide that CPR until EMS arrives. And also early defibrillation, we said, is a third link. So if you can have defibrillators at public access points that they can be used even before EMS arrive, then that's increase the chance of that person recovering. Also, recognition of the need for advanced life support. We need to have those services most of the time. When you get a call for a suspected cardiac arrest case, if you are EMTB, then in most jurisdictions in the Caribbean or even in Jamaica, you won't have any advanced care coming to you. So you'll have to take that patient to the advanced care. So it's very important if we can have the need for advanced care and a more wider spread level, then it's all gonna be better for that patient in reducing cardiovascular deaths. And transportation to hospital that can provide coronary catheterization and post-arrest care. We need to have the facilities that can do what is needed for that patient in case they need to have that definitive care where they have to have perfusion therapy, reperfusion therapy. So with every emergency that we are dealing with, you must know the system that is being impacted. And as we are looking at cardiovascular emergencies, we know that, as the name suggests, cardiovascular is dealing with the heart, the blood vessels, and the blood. And we know this is directly connected to the perfusion triangle. You did shock before, so you would have looked at it also. So you looked at the human, basically a quick revision, a quick review as we move to the main issue of the pathology as it relates to cardiovascular emergencies. What disease that can occur, how they will manifest signs and symptoms, and ultimately how you as the AEMT will deal with them, how you'll manage them. But your understanding of anatomy and physiology will always help you in knowing what to expect and how to manage these patients. So the cardiovascular system consists of the heart, the blood vessels, and the blood. And you must know the anatomical structures. What are the structures that are there? We know that the heart is like it's a muscular organ, and it's divided into the 4 chambers. You must know the connections of the blood vessel and how the blood flow through the heart. At this level, you should be able to give an outline of the flow of blood from one section of the heart to the next, and vice versa. So we know that the heart wall is made up of different layers. So you have the myocardium. This is the middle layer, which is actually the muscular layer, which is the layer that is involved with the conduction, contraction, This is the area that gives rise to the automaticity of the heart and the excitability. We also have the pericardial sac, which is the sac that surrounds the heart, and it's have the two layers as we see with most cavity. You have the visceral layer, which is the layer that is covering the heart itself, and also we have the parietal layer, which is the outer layer. Within those two layers, we have the pericardial fluid, and it reduces friction within the pericardial sac. When you have blood or excess fluid in that space, then that will give rise to the cardiac tamponade. Also, a third layer that we have aligning the wall of the heart is the endocardium, and this is the inner layer. This is the innermost layer, and it's on the surface of the valves also. So each atrium receives blood that is returned to the heart from other parts of the body. So we have 4 chambers, 2 upper chambers known as the atrium singular, atria plural, and the 2 lower chambers, ventricles. The purpose of the atria is to receive. The purpose of the ventricle is to pump blood from the heart. This is just a quick review. As we said, you would have covered this numerous times before. There are also valves in the heart which control the flow of blood in going in one direction. So you have valves that separate the atria from the ventricles, and we need to recognize that the heart is a muscular pump which is divided into 2 sections. So you have the left side and the right side, and they are actually working in unison. It's like you are having 2 separate pumps working together. So whatever is happening to the left side happens to the right side at the same time. If the right atrium contract, then atrium contract, and the left atrium contract simultaneously, and similarly with the ventricles. So these valves are there to allow blood to flow in one direction. So between the atrium and the ventricle, and the right and left, there are valves known as atrioventricular valves. So there is the tricuspid valve on the right side, and the mitral or bicuspid valve on the left side. And the easy way to remember which is which, look at the R in tri, and that's telling you that it's on the right. Once you know which one is on the right, then you will automatically know that the next one is on the left, which is bicuspid or mitral valve. There are also other valves that allow blood to leave the ventricles, and these are the semilunar valves. And you have the aortic valves, which would be allowing blood to enter the aorta, and the pulmonic valve, which allow blood to enter the pulmonary artery. Now these valves, which are the atrioventricular valves, they have what we call papillary muscles that anchor to the lining of the heart, and also connected to these fibrous tissue that actually, when the muscle contract, cause the valves to close. So this diagram gives you a pictorial view of the valves, and we will also look at the blood vessels that's connected to the heart. So we say that the right side of the heart is the side that deals with deoxygenated blood returning to the heart from the body. So you'll have the veins that bring the blood back to the heart, and we need to recognize at this point, everyone should know that Veins will always carry blood to the heart, while arteries takes blood away from the heart. So easy way to remember: A for artery, away, A away, artery, leaving the heart. So the right side is receiving blood that is coming from the rest of the body after it has been used up and is returning. So it's deoxygenated blood will come via the superior vena cava from the head, upper body, and the inferior vena cava from the lower extremity or the lower section of the body, and it will merge into that main vena cava and enters the right atrium. It's gonna move through the tricuspid valves and into the right ventricle. When it's contracted, then it will pass through the pulmonary valve and into the pulmonary artery. Again, it's artery away, and it will go to the lungs for oxygenation. And so it's the returning to the heart via the pulmonary vein. Again, entering the heart, it must be a vein, and there it is entered at the left atrium, pass through the bicuspid or mitral valve into the left ventricle, which when it's contracted, it leaves the left ventricle via the aortic valve into the aorta. You must know this pathway at this level, and also recognize that we say that arteries leave the heart with blood, and normally to be carrying oxygenated blood. But there is one exception. The rule does not change that it's an artery. It must be leaving the heart with blood, but it changes where that not every artery will be carrying oxygenated blood, and the exception will be the pulmonary artery. It's still leaving the heart, going to the lungs, but in this case, it's the only artery that will be carrying deoxygenated blood, or blood low in oxygen. And the same thing with the vein. All vein, we say, would normally, all vein enters the heart, but normally they will be carrying deoxygenated blood. But the exception to the rule is that the pulmonary vein is the only vein that will be carrying oxygenated blood. Again, at this level, we expect you to know this by heart. Also, we say that the heart can be, the sections of pump can be divided into systemic and pulmonary circulation, or pulmonic circulation. So the right side would be considered the pulmonary circulation, and the left side would be considered the systemic circulation, in the sense that the blood from the right side will be coming in and going to the lungs, while the left side will be receiving the blood from the lungs and pumping it through the body. Again, we expect you to know this by heart. Now the heart, it's a pump, it's a muscular organ, so it have to be supplied with its own blood vessel. So even though it is dealing with pumping blood to the body, itself needs its own blood supply, and this is done via the coronary circulation. So you have coronary arteries that leave the aorta and supply the heart muscle, and also you have the coronary vein that will take the blood back to the right atrium at the point of the vena cava. So it collects in the sinus and enters into the right atrium. So they are main. For the coronary artery, you need to know that there is the left main coronary artery, and it's divided into the left anterior descending, and also you have the left main divides into the circumflex coronary artery. You also have the right coronary artery, which will supply the right side of the heart. So for the left main coronary artery, it's gonna be supplying most of the left ventricle, the intraventricular septum, the atrioventricular node, and we will look at nodes further, but just recognize that the heart is supplied by, gets its blood supplied via the coronary artery, and this play an important part when it comes to damage to the heart muscle. Depending on where the blockage is in the coronary artery, it will give rise to which section of the heart is damaged. And here we see the diagram of it. You can look further at it, but just recognize that you have the anterior view and the posterior view. For the anterior view, we said that the left main coronary artery, it will branch into the left anterior descending LAD and also the circumflex, which will supply the lateral aspect of the ventricle and also the left atrium. And also you will see that you have the right coronary artery, which will supply the right ventricle, right atrium, and sections of the SA node in some persons. Now, as it relates to blood vessels, we said this before, that arteries will transport blood through the body, and the largest artery in the body is the aorta. And we have from the aorta, you have, it goes smaller into arterioles, and then you have capillaries. So the capillaries is where you actually have the exchange of oxygen, nutrients taking place at that level, which is a one cell thick structure. And from the capillary, it's going to be returning to the heart via the venules at the smaller level, and then it will merge into the veins. So you must know the blood vessels. You're going to have arteries, which carry blood away from the heart. You're going to have arteriole, which are a smaller layer of the artery that will merge into capillaries. And we say capillaries is basically the link between the artery and the vein, or the arteriole and the venules, and that's where you have the exchange taking place, oxygen and carbon dioxide. Oxygen goes into the body cells and carbon dioxide is taken out or removed. And you need to recognize that's how you have, that's the blood vessels that we are dealing with. Superior vena cava and the inferior vena cava return deoxygenated blood from the body to the right atrium, and that's we say is the right sided pump, and we say it's the pulmonic circulation. Blood from 4 pulmonary veins enters the left atrium. So the blood is gonna leave, once it enters the right atrium via the vena cava, superior and inferior merge together, then it's gonna pass through the tricuspid valve and into the right ventricle. It's gonna leave from the right ventricle via the pulmonic valve and into the pulmonary artery, which goes to the lungs. Its blood is oxygenated via the capillaries are wound around the alveoli, and the diffusion take place. The blood, oxygen enters the blood, it's oxygenated, and it's transported via the pulmonary veins into the left atrium, passes through the bicuspid valve into the left ventricle. When it contracts, it's leave the left ventricle via the aortic valve into the aorta, and that's your systemic circulation. And the process continues when it goes to the body cells. Again, diffusion takes place, exchange takes place, oxygen into the body cells, waste produced from metabolism, CO2 more so, and it's taken back via the venule, vein, back to the vena cava, and this cycle continues. You must know this by heart. So this is exactly what we have just discussed. You can look at it and ensure that you can describe the flow of blood from any section, from the pulmonic side, from the systemic side. You must know that, and remember also that the pulmonic side is a lower pressure pump than the systemic circulation, which is the left side pump. It's under more pressure, and so we'll find that the left ventricle will be a very thick walled in comparison to the right ventricle, because it have to be pumping blood under a greater pressure. And we will talk more about preload and afterload. Looking at the cardiovascular system and cardiovascular emergencies, we've said that the system consists of the heart, the blood vessel, and blood. So the components of blood, it has a plasma, which is the liquid medium in which carries the formed elements, and it makes up about 50% of the blood volume, and it is made up of about 90% water. So it carries the formed elements in the form of red blood cells, and also you have which the red blood cells is a unit that carries the oxygen, and another name for the red blood cells, erythrocytes, or they call it RBCs. You have also other form element in the blood, in the plasma medium. You have white blood cells, WBCs. These are the leukocytes, and they are responsible for fighting infections. They are the soldiers of the body. And also you have platelets, which are important in clotting. Now, the heart cannot function without a electrical conduction system. So I said before that the heart muscle, the myocardium, the muscular layer of the heart, the middle layer, it has what we call automaticity, and also it's excitable, and it's also allow for conduction and contraction. So this myocardium, the cardiac muscle in itself, is a very unique muscle. It's the only of its kind in the heart, in the body, and it's in the heart, which has this automaticity. So normally organs or structures have to be stimulated via a signal from the brain, but the heart does not need any impulse from the brain to cause it to work. It can work on its own, and it can be regulated by the signal from the brain, but it does not have to have that signal from the brain for it to work normally. So you have the heart pumps in response to electrical stimulus initiated by a conduction system. So you have conduction pathway in the heart muscle, and the source of this impulse is generated via the sinoatrial node, SA node. This is the pacemaker of the heart. This is the site of origin of the electrical impulse, and this impulse will generate a intrinsic rate of 60 to 100 beats per minute. So this is the main source of impulse for the heart to contract. The impulse will be spreading out from that SA node and results in ventricular contraction or systole. So you have different points or sites where signals will generate from, but anywhere along that conduction pathway, signal can be derived because we say it has what we call excitability. So the conduction pathway can become excited anywhere along that pathway, but the main signal will originate, or the pacing will start at the SA node, and the SA node is located at the upper right atrium, right at the junction of the vena cava. And from there, the pathway continues with internodal pathway through the atria, and both atria, you have pathway going through that will eventually link up with another main site, which is the atrioventricular node, which is the AV node. And that node is right at the lower section of the atrium, right atrium, at the junction of the tricuspid valve, right behind, sits right behind it. And the signal will arrive there. Once the signal passes from the SA node to the AV node, it will cause the atria to contract. And we say the two pumps, the right and left pump, it will work simultaneously. So once the right atrium contract, the left atrium is contracting simultaneously because of those internodal pathway. Once the signal reaches the AV node, it's gonna pause there to allow the ventricles to fill with blood. And we will see that represented in the ECG tracing when we look at it. But just get that picture of what the electrical signal is doing, and you will have an idea of how your ECG should be represented. From the AV node, once it pause is completed, it will move via the bundle of His, which will then goes to the left and right bundle branches, which at this point is signal passing through the septum of the heart, and then it will move to the fibers called Purkinje fibers, which flows through the complete wall of the ventricles, and that's how you will eventually get your ventricles contracting once signal passes through the bundle of His bundle branches and the Purkinje fibers. So just to go back to this, so it says that impulse spread out and result in ventricular contraction or systole. So once the ventricles contract, that's systole. Once they relax, then that's diastole. Therefore, in systole, the blood is pumped out, and that's what you'll get from for your blood pressure. That upper number, systolic blood pressure, and when it relaxes, there is still some pressure there, and that's your diastolic blood pressure. What we also need to recognize as we are looking at electrical conduction system is that when the signal is passing through, it is saying that there's an impulse being generated, but because an impulse is generated does not mean all the time that there is mechanical action of the heart. You can have signal passing through and there is no contraction. So electrical system is telling you that the impulse passed through, but it doesn't have to say that mechanical capture is there. So you will have to look at it separately, and that's where we come when there's myocardial infarction. There can be damage to the heart muscle, and you might not be getting the contraction as you should. Now this is just a diagram of what I just explained. You will see the SA node, sinoatrial node. That's the main site of the impulse being generated. That's the pacemaker, and we say the value there is 60 to 100. That's the normal rate of the heart. We also see the internodal pathway going through down, passing through the atrium, right and left, and also reach to the AV node, atrioventricular node, where we say the signal will pause and then it will move through the atrioventricular bundle or the bundle of His, and then it will go down the bundle branches left and right, which is passing through the septum, and the septum is the dividing wall of the heart, which we say actually separates the heart into two separate pumps, two separate sides. Blood from the right side will never be mixed with the left side. When we are a fetus, we have that occurring, but once a person is born, then that hole that was there is closed, and there is no more mixing of blood from your right side of your heart to the left side, unless there is some birth defect. But the septum is the middle wall separating the two sides. Again, the signal will go to the Purkinje fibers, which will innervate the walls of the ventricles and cause the contraction of the ventricle when they are stimulated. Again, this is basically should be revision, so we expect you to know all of this at this level. Again, I said the properties of cardiac cells, the electrical properties are that they are excitable, so they can be stimulated anywhere along that electrical pathway. Once it's a conduction pathway, it's possible for stimulation can occur at any point, and that is what will give rise to our these arrhythmias. When they have different areas along the pathway become excitable and takes over the pacing of the heart. You also have the fact that these cells are allow for conduction. They have conductivity properties, and also so they are able to conduct electrical impulses. And also we say they have what we call automaticity. So they are able to contract without a stimulus from a nerve source. It doesn't have to be getting any impulse from the brain. The heart will always be able to generate its own impulse, and it will generate it from different sources. If one source fails, so if the SA node fail, then the AV node will pick it up, and when the AV node pick it up, the lower down you go, the slower the rate will be. So if the AV node is the side that is triggering it, it will be 40 to 60 will be the rate, and if the AV node fails, then the ventricle will pick it up with their rate of 20 to 40. So that's what we are looking at. The heart will always preserve itself or attempt to preserve itself once there's a problem until there's no more preserving or compensation, and that's when you will end up having your ventricular fibrillation moving into asystole, and that's what will happen. So now that we have looked at the anatomy and we're looking more at the physiology, how the heart function, the regulation of the heart function, we say that the heart will always generate its own impulse, but the autonomic nervous system can control or provide some regulation, and it's in the form of when we have stress or condition that cause the sympathetic nervous system to come into play and cause the heart rate to increase. It causes the strength of conduction to increase, and also the force of contraction to increase. And so you will have the conotropic state, is where you have increased rate and rhythm of contraction. You have inotropic state is dealing with the increased force of contraction, and the domotropic state is when you have the strength or velocity of the conduction is increased. And this is regulated by the autonomic nervous system, the involuntary part of the nervous system, where we say that you have the sympathetic and parasympathetic nervous system will come into play, where sympathetic will cause these things to speed up, while parasympathetic will slow them down. But as we say, without this external stimulus from the brain, the heart will always generate its impulse at the intrinsic rate of 60 to 100 from the SA node and till condition changes. Receptors constantly monitor body functions to maintain homeostasis. So the body is so beautifully designed, it will always try to maintain this state of equilibrium, state of balance, where everything is working perfectly the way they should. And so you have a series of networks of systems set up where you have feedback loops, checks and balances, so that if something goes out of the predetermined range or level, then there is some corrective measures that will be put in place to bring it back in line or into the range that it should be. And this is, you could call it our compensator mechanism. Disease or injury, these compensator mechanism can be overwhelmed and they will decompensate until the problem can be rectified. Also, we have baroreceptors. These are pressure receptors. They respond to changes in pressure, and you have them along the internal the carotid artery and also the aortic arch, which will pick up changes in pressure, and the corrective measures will be put in place to correct it. Also, you have chemoreceptors. These are respond to chemical changes, and once there is any change, it will be sent to the brain and the necessary corrective measures will be put in place. As we continue to look at the physiology of the cardiovascular system or the heart, we recognize that a cardiac cycle is one contraction, the beginning of one contraction to the beginning of the next or the ending of it. So the process that creates the pumping of the heart, and it begins with the myocardial contraction and concludes at the beginning of the next contraction. So that is a cycle, and we say that you have the systole is the contraction of the ventricles and the pumping of blood into the systemic circulation, while diastole is when the heart relaxes. So the relaxation of the heart will allow the ventricles to refill with blood until the next contraction. So you will always have systole, diastole, contraction, relaxation, and we will see with the electrical signal, it causes the cardiac cells will be in a polarized state, relaxing, resting state, and they will be depolarized to cause that contraction, and then that they have to be repolarized and to start that process all over. So the cardiac cycle will be from the signal starting from the SA node, passing through the atria, going to the AV node, relaxing, allowing the ventricle to fill with blood, then passing through the bundle of His, down the bundle branches, and innervate the ventricular wall via the Purkinje fibers and cause that contraction. Then the signal will have to be repolarized and get to the beginning of the cycle again, where it's ready at the SA node again to start that cycle. So that's your cardiac cycle. So we mentioned preload and afterload. So preload is the amount of blood returned to the heart to be pumped out. So it's the ability of the ventricles to stretch to receive that blood. So the more stretch you get from it, the more forcefully it will contract. Just imagine you're having a slingshot, and the more you can pull it back, the further you'll be able to send that shot. So preload is that ability for the ventricles to stretch to receive the blood. So the amount of blood returned to the heart to be pumped out. So the more blood return and is filled in the ventricle, then the more blood will be pumped out. So the greater the preload, the greater will be the cardiac output. The less the preload, less cardiac output. Now with afterload is the pressure against which the ventricles must pump blood. So the blood vessels offer some resistance. That's the systemic vascular resistance, the amount of resistance in the whole systemic vascular bed. So it will offer some resistance to the force that the ventricles are pumping with, and that is what we call afterload. So the greater the afterload, the more impact will have on the output. So factors that influence the heart rate, the stroke volume, or both will affect cardiac output and perfusion, because cardiac output is actually this stroke volume times the heart rate. So whatever volume of blood is being pumped in one stroke times the heart rate, that will give the cardiac output. And so if less blood is pumped out and the heart rate reduce, then you will ultimately reduce the cardiac output. If you increase the heart rate and even don't increase the volume, then the output will increase. So either one or both increase will allow for an increase in output. Either one or two decreases, then output will be affected, and ultimately perfusion, and ultimately blood pressure. So the Starling law of the heart is the greater the force of the stretch is, the more stretch there is, then the more force of the contraction, the greater the force of the contraction. We looked at the blood flow within the heart, and we went through this extensively. Everyone should understand this. In the lungs, the blood is oxygenated and carbon dioxide and other waste products are removed. So we have that diffusion taking place at the level of the alveoli, where the capillaries, blood capillaries, are wound around the alveoli. The air comes in with the oxygen, and we know that the composition is 21% oxygen in that inspired air, and you have about maybe 5% carbon, 16% oxygen in the blood, and so it will cause for diffusion. Oxygen will move from the alveoli with a greater concentration into the blood capillaries. And same thing with carbon dioxide. Inspired air have about 1% or less than 1% carbon dioxide. The blood capillaries, blood in the capillaries around the alveoli have about 5% because of waste being generated from metabolism. So you have movement of molecule, higher concentration in the blood capillaries, allow it to move into the alveoli, and that exchange is taking place right at that level. So freshly oxygenated blood is returned to the left atrium because of that diffusion through the pulmonary veins. And after oxygenated blood has been delivered by the capillaries, the oxygenated blood is returned to the heart. And this is review, as I said, you have diffusion number 2 taking place at the cellular level, where at the body cells you have higher concentration of oxygen again at the cellular level will diffuse into the cells, and you have CO2 being diffused into the blood capillaries and taken back to the lungs, and the cycle continues. You must know this blood flow within the heart, by heart at this level. For the pulmonary circulation, we said that it's gonna be coming from the right side, where blood is carried from the right side of the heart to the lungs and back to the left side of the heart. And for the systemic circulation, it's from the left side where it enters the pulmonary vein and carry blood from the lungs to the left atrium via the bicuspid valve or mitral valve to the left ventricle, and is pumped out to the rest of the body. So systemic circulation is responsible for blood flow to the rest of the body. Systemic arterial circulation, oxygenated blood leaves the heart through the aortic valve and passes into the aorta. This is what you should know at the tip of your brain. Now that we have looked at anatomy and physiology, I think I've gone into more depth than what should be just a review, but I hope it would have cemented the information for everyone. We are going to be looking at the meat of the matter now, pathophysiology. As AEMTs, this is your focus. The background information will help you, but this is your focus. What you'll experiencing when you go there, what the patients will be experiencing to qualify that emergency, problems that can be happening to the system, and how it will be manifested and how you treat it. So chest pain or discomfort related to the heart usually stems from cardiac cell ischemia. We said that the heart must be supplied with the coronary artery to feed itself with blood. Even though it's pumping blood, it needs to get its own blood supply to keep its cells, heart, the muscle cells, so that they can function properly. So any problem with the coronary artery, once they are blocked, they will affect the heart's ability to function, and it will give rise to chest pain or discomfort, and that is what is coming from cell ischemia. So the lack or deficiency in oxygen supply to this heart muscle cells will give rise to that chest pain or discomfort. And it's decreased blood flow to heart muscle. Heart tissue fails to get enough oxygen and nutrients, and eventually they will die. So if it's not corrected, you'll have these ischemic cells will become infarcted cell. Death of the cells will result. So atherosclerosis is a condition where you have plaques or fatty fats build up in the wall of the blood vessels, and we're talking about the coronary artery. It relates to the heart. It's gonna happen all over the body, but we are focusing on the cardiac system, so it's in the coronary. That's what we are looking at now. And so coronary artery atherosclerosis diminishes blood flow to the myocardium. So once you have these plaques and fats build up, it's gonna occlude the lumen of the artery. So it's gonna be a smaller area for the blood to flow, and actually it can lead to complete occlusion where no blood flow is taking place. So any area that is below the point that become occluded will not get any blood and not get any nutrient and oxygen and our oxygen. And extensive damage to arteries prohibits accommodation of increased blood flow. So you have atherosclerosis and you can have arteriosclerosis. So the atherosclerosis can lead to arteriosclerosis, where the blood vessels become so hardened from these deposits they cannot dilate and constrict as needed, so the blood flow cannot be regulated in them. And once there is increased demand, they cannot dilate to accommodate it, and that's where you'll have these problems coming up. So one thing lead to another. So this is what we see, a picture representation of what is happening. So atherosclerosis can cause a reduction in blood flow, and we see where you have the normal arch with the widened lumen, complete rounded lumen, and then when it is become atherosclerotic, you will see it becoming narrowed, or it can come to the point of complete occlusion. So it can cause from a thromboembolism. So you can have the plaque, the cholesterol build up in the wall of the coronary artery we are focusing on here. And you can also, that in itself can reduce the blood flow because it reduces the lumen size. And also you can have another problem where a clot breaks off, the clot is formed, and you can have a crack and a piece of it become a thrombus, and it embolize and move to block a narrower section of the coronary artery. So thromboembolism, blood clot that gets stuck at a narrow area, blocking blood flow, and you can end up with acute myocardial infarction. The blockage in a coronary artery is so bad that the area below it becomes so ischemic, and eventually the heart muscle cells die and become infarcted and turn scar tissue and affect the function of the heart. So major controllable factors, and we spoke about this from the beginning of the class or chapter, because these are things that we say, these are things that we can control. These are controllable risk factors that will predispose us and our patients to having these cardiovascular emergencies. They prevent them from having atherosclerosis, which is the buildup of these plaques and fat. What can we do to prevent them? Major thing. Cigarette smoking promotes that. High blood pressure will lead to those plaques and fat and lead to atherosclerosis. Elevated cholesterol levels, big factor that can cause it, and that can be controlled. Watch our diet. Elevated blood glucose levels, again, predispose us to having those atherosclerosis. And lack of exercise, sedentary lifestyle, stress, all those. And like I said, these are for our patient, but we have a bearing on us also. We first have to make sure that we are healthy. Otherwise, we cannot go out there and help anyone. So acute coronary syndrome is a condition, group of symptoms consistent with acute myocardial ischemia. So anything that will decrease blood flow to the heart muscle, to the coronary artery, will be grouped as will be termed acute coronary syndrome. So describe any group of symptoms consistent with acute myocardial ischemia. Myocardial ischemia, this is where you have decreasing blood flow to the heart. Both conditions have similar signs and symptoms and treated similarly under the designation of ACS. So myocardial ischemia, acute coronary syndrome, is basically treated the same, and it comes under that acute coronary syndrome. Now we'll see this term coming up, angina pectoris, and this is where you have the pain that is experienced by the patient, or discomfort, and it's a brief period when the heart tissues are not getting enough oxygen. So there can be an increased demand, and it cannot compensate for that demand, and this gives rise to that angina pain. And it's gonna be described as crushing, squeezing, felt in the mid-chest, under the sternum, And we talked about this earlier on when we were looking at neurologic emergencies, where because of the nerves that are in the visceral and parietal layers, it can give rise to pain being felt or discomfort felt elsewhere. Therefore, you have pain of angina can be radiated to the jaw, arms, and more so the left arm, the mid-back, or epigastrium. Therefore, we have to be mindful when the patient is having pain in these areas, and in conjunction with that chest pain, think that it can be a cardiac issue. A single episode may cause myocardial infarction. Just a single episode can be as deadly as that if it's not corrected in time. So you have described angina as stable or unstable, progressive. So stable angina is relatively easy to recognize. It's when the person will have an issue based on stress, and they know this is as a result of they are undergoing stress, and so it's predictable. While unstable angina is when there's no, the person can be sitting down and they just start to have that pain, so there's no stress causing it. That is unstable, and that's going to be a worst case situation, where stable angina can be just from ischemia, but unstable can be leading into myocardial infarction, and you might not be able to differentiate it. You just have to treat the patient accordingly to their presentation. And you have progressive angina, stable or unstable angina that is accelerating in frequency and duration, and this is again suggesting that the condition is worsening. So normally we say when it is stable, the person usually is relieved by rest and or medication. So they were moving up, walking up a staircase, and they have the pain, and once they get to the top and they rest, then the pain subside, then we could say that's stable angina. If they were sitting and the pain just come on, and they were walking and they come on and they sit and it's still there, then you would say it's unstable, and it's suggesting a bigger issue, worse condition. So from simple angina, we're gonna move to acute myocardial infarction. So we say the cardiac cells, they can become ischemic, and if it's not corrected, then we say that it's gonna lead to death of the tissue. So pain of acute myocardial infarction signals the actual death of cells in the ear of the heart where blood flow is obstructed. Angioplastic or percutaneous coronary interventions, PCI, are shown to be the most effective treatment. So whatever is causing the issue in those coronary artery, if it's a blockage that can be relieved by medication, they can give them clot busters, fibrinolytic therapy, or if that is not helpful, then they can move to what we call putting a stent inside there and opening it up, or using that to remove whatever is blocking it. With acute myocardial infarction, signs and symptoms, again, once you understand the physiology, what is happening now, how it should work normally, then you can know what will happen when something is not right. You can actually tell what you should be seeing once you know the anatomy and physiology. So the patient will have sudden onset of weakness, nausea, and sweating, and this is coming from the stimulation of the sympathetic nervous system. Once there is a short ischemia, oxygen deficiency, then the body nervous system gonna come into place to try to get more blood into the area, thereby getting more oxygen into the area, and this is what will give rise to most of our signs and symptoms. The patient will have the chest pain, discomfort, or pressure because the cardiac cells are crying out because of that lack of oxygen. We say we'll have the ischemic angina pain moving into pain of infarction, and you will also have pain, discomfort, or pressure in the lower jaw, arms, back, abdomen, or neck. We say this is because of the referral due to the connecting nerves. You'll also have irregular heartbeat and syncope. It will affect their electrical conductance of the heart. You can have dysrhythmias, shortness of breath, or dyspnea. Again, the lack of oxygen will cause the person to have difficulty breathing, and also pink frothy sputum. This is where you have left-sided heart failure. The blood is gonna back up. It's coming from the pulmonary vein, coming from your lungs. It's gonna back up into the lungs and cause fluid to get into the alveoli. And eventually, if it's not treated, can result in sudden death. So once you understand what is going on, how it should work normally, then you can just see what these signs and symptoms will be even before you see them. You should know, and once you see them, you should have an idea, better appreciation of what is going on. So acute myocardial infarction, the most common symptom is chest pain. So the most thing the patient gonna complain of chest pain. Physical findings of AMI, patient often appears frightened because they can feel like they are dying. They will tell you that they feel like they're dying and don't take it lightly. Pulse will increase. Again, we say that's because of the sympathetic stimulation, that chronotropic state. Blood pressure may fall because eventually cardiac output will be affected, depends on what is happening, and that we say affect perfusion and ultimately blood pressure. Difficulty breathing, we said it's because of the ischemic hypoxic state that the patient is developing. They will have that difficulty breathing eventually. Overwhelming feeling of impending doom. They feel like they're gonna die. Somebody feel like somebody is squeezing their chest, crushing chest pain. It's a real frightening experience, and so we have to be reassuring to our patient. We have to reassure our patients and try to empathize with them, reassure them. What are the consequences of this AMI? The consequences: worst case scenario, sudden death. They can have cardiac arrest. They can have cardiogenic shock, which is where the heart fails to function as effectively as it should, and so it results in low cardiac output. Cardiac output is affected, and they will go into cardiogenic shock, and you can have heart failure. Because of heart failure, the heart is not able to deal with the amount of blood coming in, and so you will have backup of blood taking place. This gives rise to our congestive heart failure, left or right side or both. Other lethal and non-lethal dysrhythmias, the heart can give rise to different rhythms, tachycardia, rate over 100. We say the intrinsic rate of the SA node, which is the pacemaker, is 60 to 100. So in tachycardia, anything over 100 beats per minute, or it can become bradycardic, where it's less than 60. You can have ventricular tachycardia. Again, we say when the signal fails to be generated from the SA node, the AV node will pick it up. If the AV node fails, then the ventricle is gonna pick it up, and it can be occurring at such a fast rate that it's becoming ventricular tachycardia. And again, this can give rise to no pulse, and where this is a lethal rhythm, or it can be still pulseful but can be having symptoms. It can give rise to other dysrhythmias, ventricular fibrillation, where the ventricles are contracting so fast, it's as if they're basically fibrillating, and this does not give rise to a pulse. You will never get a pulse from a ventricular fibrillating heart. And also you can end up with asystole, where there is total cessation of electrical activity, and that's your flat line. So this shows you some representation of some heart rhythms, and you will need to know them. The first one is the perfect normal heart rhythm, normal sinus rhythm. And a normal sinus rhythm will always originate from the SA node, that's the pacemaker of the heart, and it will have some specifications that you must know, some key features that will make it a normal sinus rhythm. Number one, it must have the intrinsic rate of 60 to 100. Number two, it must be a normal rhythm. Each cardiac cycle must be going at the same rate and pace. Also, we said that the electrical signal passed through from the SA node through the atria via the internodal pathway, and then it reached to the AV node. So every normal rhythm must have an upright and rounded, the signal passing through the atrium or atria. Again, I said it tells you that the signal is passing through, but it does not tell you that the heart muscle is contracting. That's what we are seeing with the ECG tracing. It is just giving you the electrical representation of the activity of the heart. Also, for a normal sinus rhythm, it must have a normal QRS complex, which is nice and narrow, and you must have a P wave preceding the QRS complex. Now, there are some other specifications which you should know, that the P wave pause between the signal moving from the AV node is what we call the, from the P wave to the beginning of the QRS complex is the PR interval, and we look at the time it takes. When we look at the ECG representation, it should take between 3 and 5 small boxes. That's another key thing you know for a normal rhythm, sinus rhythm. And for the QRS complex, it should be less than 3 small boxes. And once you see those characteristics, you will know that you're looking at a normal sinus rhythm. If the rhythm is not a normal sinus rhythm, we looked at tachycardia before and bradycardia. So the second one you are seeing is a sinus bradycardia, and that's where you have its rate is over, it's under 60. So you will see that everything is the same as a normal sinus rhythm, except that the rate is less than 60. For a sinus tachycardic rhythm, it will be the same as a normal sinus rhythm, except that the rate will be over 100. The third rhythm you are looking at is what we call a ventricular tachycardia. This is where you have a monomorphic ventricular tachycardia, because it is looking all the same. All the waves are the same. So mono meaning the same shape and morphology. Again, we see that there is no discernible P wave. You just see some shape there, which is representing the ventricles generating that signal. And the fourth one is, everybody should know this rhythm by heart. That's ventricular fibrillation. This is represented by chaotic movement, total disorganized movement. The signal is occurring all over in the ventricle, and that's how it is represented. No pulse will be generated by this rhythm. You cannot see this rhythm and ask anybody if there's a pulse. If you are doing your scenario in your mega code, you will never ask if there's a pulse from this rhythm. And whereas if you are in the field, no pulse will be generated. And it's the same with asystole. The one at the bottom, that's your flat line. Never generate a pulse. But what you should do once you see it on the monitor is to check to see if the lead is on. The lead can be disconnected and you're getting a flat line or asystole rhythm and you're saying it's a flat line, but always check the leads. And at the end of the day, we always say, don't treat the monitor, treat your patient. So you cannot have a patient talking to you and you're getting a flat line and you're saying the patient is in asystole. Those two will never be together. There are some other rhythms that you will need to know, but I'll just go through these as they are there. Now, in cardiogenic shock, we say that is when the heart not being able to pump enough blood as it should, so its pumping action is affected, and so cardiac output is affected. So often caused by a myocardial infarction. So a section of the heart muscle is damaged, and so it cannot pump effectively, and so it lacks enough power to force blood. Differentiated from hypovolemic shock by. Differentiated by hypovolemic shock by. So it will present itself similarly in some ways, but you need to recognize that there will also be some differences. And we mentioned the word other day, subtle signs. So these are signs that you might overlook. They might not be obvious, and you might mistake them for something else. But again, you should be able to pick them up. So what will differentiate a cardiogenic shock from a hypovolemic shock? The chief complaint will be different. So the person will be having that chest complaint. With hypovolemic shock, they're not necessarily going to have that chest discomfort. It's going to be more like bleeding or vomiting, diarrhea. So the chief complaint will going to clue you in that it's more of a cardiogenic shock. The heart rate is another thing, can be similar in a sense with hypovolemic shock, but that can be another issue. It can be irregular. You can be having dysrhythmias. Normally, that wouldn't be the case with hypovolemic shock. Peripheral edema, and that's where we have the right sided heart failure, where fluid is backed up into the circulation, systemic circulation, so it pulling in the point of lowest. So you have dependent pedal edema and dependent edema. You have dysrhythmias, you have jugular vein distension again from the backup of blood, and the ultimate edema in the jugular vein, the blood pooling and cause that distension. You have crackles and auscultation of breath sounds, which is coming from the left-sided heart failure when we have fluid back up into the lungs, pulmonary edema. So these are signs and symptoms that the patient will experience that will clue you in that it's more of a cardiogenic shock than pulmonary, than hypovolemic shock. Some initial evaluation and treatment as a patient reporting chest pain, and treatment as patient report chest pain. So they will have signs and symptoms. They'll start with becoming anxious and restless as the brain is being deprived of oxygen. They will have ear hunger, again hypoxia, high pulse rate, sympathetic nervous system will come in, and that chronotropic state where increasing heart rate. rapid and shallow breathing, nausea and vomiting, decrease in body temperature. Again, that's compensatory mechanism where the blood is being shunted. Low blood pressure as the condition worsens, then perfusion is affected and low patient becomes hypotensive. Treatment is geared at, as always, you will always go with your A, B, C, D, E, and so positioning is key for these patients, and some of them in that they will always feel better sitting up once they are conscious. I guess again you will have that ear hunger. You will always ensure that they maintain their O2 oxygen saturation between 94 to 98%. If they need assistance with their ventilation, if they are breathing shallow, you will need to assist with their ventilation. As AEMTs, you would ensure that you connect your cardiac monitor, get that capnography reading for them, entitled CO2. You want to see what their ECG reading is. If time allow, you get a 12-lead ECG. Again, they will be in that state where shock state, so you need to preserve their body heat, cover them, keep them warm. Again, they will be hypotensive, so you want to get their blood pressure up over 90 millimeters of mercury systolic. So you need to gain IV access to give fluid resuscitation. Again, you might have to give medication, transport to an emergency department. Again, recognize that there's so much you can do out in the field. Even though you're an advanced, there's a limit to your scope of practice. And so you would call for your paramedic backup if it's available in your jurisdiction. But at the end of the day, recognize that you need to get that patient into the care, definitive care, where they need to get that. We said they might need reperfusion therapy. They might be candidate for fibrinolytic therapy, where they can get clot busters to break up the clots if they're having clots in the coronary artery. And also to call in, if you had done your ECG report, you can submit it also and make sure you alert the department with type of patient you're coming in with, so they can be prepared for you. As it relates to heart failure, and we said this is where the heart is not able to accommodate the amount of blood that is coming in because of either disease, damaged valve, occurs when the ventricular myocardium can no longer keep up with the return flow of blood from the atria. Can occur anytime after myocardial infarction, so it can be from damaged heart muscle, heart valve damage, long-standing high blood pressure, and give rise to enlarging, the ventricles might become enlarged, and so they cannot function effectively, and you have blood will start to back up. So we have it can be left-sided heart failure, where the left side fails. If the left side fails from whatever reasons, as we said before, then ultimately what's going to happen? The blood is going to be backed up into where it's coming from. And where does the left ventricle, left side of the heart, get its blood from? It's going to be coming from the pulmonary vein, coming from the lungs. So if it's not going to be flowing properly through the heart, through that left side, and it's going to back up into that pulmonary vein and ultimately back up into the lungs. So pumping function of the left ventricle can be damaged by coronary artery disease, heart valve, chronic hypertension. Heart rate increases and left ventricle enlarges to increase the amount of blood pumped each minute. Eventually, it will become overwhelmed and congestive heart failure result. The blood is going to start to back up. And we will play out with the condition, the sign and symptom that we will see for the left sided heart failure. It's gonna be ended up with pulmonary edema. The blood is gonna back up to the capillaries around the alveoli, and eventually it's gonna be overwhelming the walls of the alveoli, and enters into the alveoli, and you will have your pulmonary edema. The patient will have pink frothy sputum. They can be so you will experience, that's the signs and symptoms. And these patients gonna be very important with the position. They will feel better sitting up if they are conscious. For right-sided heart failure, in this case, the right side fail from whatever same reasons, the damaged heart muscle, valves, high blood pressure cause the ventricle to become enlarged, and it's not able to accommodate the blood coming into it. So it's gonna back up, and this is where we're gonna have it. Where's the blood coming from entering the right side? It's coming from the vena cava. It's coming from the rest of the body, the upper body, the head, the lower extremities, the lower body. So it's gonna be pulling back into this area, backing up into this area. And so that's what gonna give rise to our dependent edema, pedal edema. You'll have enlarged liver. You'll have jugular vein distension. You'll have fluid even backing up into the abdomen, ascites. All of these things will play out. So if right side of the heart is damaged, fluid collects in the body, often showing up as swelling in the feet and legs, collection of fluid in parts of the body closest to the ground. So wherever the center of gravity is acting, if the person is on their back, then you will see that sign of the pooling of the blood in their back and swelling in the feet and lower legs. You must understand what's going on, and once you see these, you can have an idea which side of the heart is failing, and both sides can fail together. One start with one, and then it end up on the other side. So you can have the person experiencing both conditions. Heart failure, signs and symptoms, we'll see. You can just list them for yourself based on what is physiology, what is the pathophysiology, what is happening. You can know all of these signs will come out. Atropnia, patient will experience difficulty breathing when they are in certain position. So they will feel worse when they are lying down. They will feel a little better when they sit up or stand. And that's can be explained from the pulmonary edema, the fluid in the lungs. Patient is agitated. Distended neck vein, we say it's from the right side, that will be coming from backing up in the systemic system. Swollen ankles from pedal edema, similar thing is happening, backing up in those areas. Use of accessory breathing muscles, they are struggling to breathe. They're gonna be using up getting all the help they can to get that oxygen in and trying to force oxygen into the body. Crackers from the pedal pulmonary edema. Productive cough, because we say the fluid in the lungs, it gives rise to pink frothy sputum. So they'll have a productive cough. Delayed capillary refill time. That's gonna be happening from compensatory mechanism, gonna be shunting blood from the extremities to preserve the core organs. What are treatment for the right-sided heart failure? We know what's happening. It's gonna be fluid backing up in the systemic circulation. So you need to always go with your ABCs, manage what needs to be managed. You need to give the patient O2 if indicated, oxygen, ventilate them if needed. Get your cardiac monitor, entitled CO2, capnography reading. You need to auscultate lung sounds. At the end of the day, patient is hypotensive, you need to gain IV access, administer fluid resuscitation, get that blood pressure, if possible, above 90 millimeters of mercury systolic. nitroglycerin if the patient blood pressure can tolerate it, and that's above 100 millimeters of mercury. Obtain your vital signs, monitor the heart rhythm. If you can get an 12-lead ECG, you get it. Your basic supporting their ABCs. That's the bottom line, and recognize the need to move with your patient for definitive treatment. For pulmonary edema, which is suggesting left-sided heart failure, fluid passes through the walls of the capillary vessels and into the alveoli. So it's going to back up and the pressure is going to overwhelm the wall of the alveoli, the wall of the capillary and the wall of the alveoli, and the fluid enters the alveoli. It can lead to respiratory failure and eventually death. Remember, if that the fluid in the lungs is going to affect the diffusion of oxygen into the blood vessel, and eventually hypoxia to the brain. 4 to 6 minutes we stay without oxygen, brain cells can start to die. So what's going to precipitate this is that heart failure, so damage to valves or long-standing high blood pressure, myocardial infarction, cause the heart not to be able to function properly and accommodate the blood coming into it. Pulmonary embolism, again, there's a blockage in the pulmonary artery, cause the blood to also pressure to build up, or anywhere in that pulmonary circulation will cause the blood to flow to be affected. And cardiomegaly is when you have enlarged heart. So all of these can give rise to the left-sided heart failure, which ultimately give rise to the pulmonary edema. We mentioned preload and afterload, and this will influence the buildup of pulmonary edema. So we say it's the ability of the preload is the ability of the ventricle to stretch to accommodate the blood. And so if it is not, if there's pressure involved in the stretching, then it will also cause the pressure to build up and cause the overwhelming of the walls of the capillaries wall and the alveolar wall, and cause fluid to build up in the back up in the alveoli. Similarly with afterload, if the pressure systemic vascular resistance increased to such a point, then the pressure will be so great that you'll have the pressure back up, and ultimately it goes back to the lungs and cause that overwhelming of the wall by the fluid which enters the alveoli. Treatment is focused on maintaining the airway, breathing, and circulation. So the patient will have difficulty breathing, manage their airway. Again, they might have the secretions, so suction as needed. Assist them with their ventilation if needed. Supplemental oxygen, get that up to 94 to 98%. Get your capnography reading. Listen to their lung sounds. You'll hear crackers more than likely. Transporting the patient for definitive care. They need to, if you can have CPAP therapy is indicated in this case once there is no other contraindication, because the CPAP will be able to give that pressure to overcome the pressure that is in the lungs and blow that fluid back out of the alveoli. So CPAP is an indication there, but if you need to move to advanced airway management based on the patient condition, then you follow your protocol. But at the end of the day, you need to transport the patient for definitive care. Hypotensive emergencies, this is where the blood pressure becomes so great that it's gonna cause negative effect. So occurs when only with systolic pressure of greater than 180 millimeters of mercury, rapid increase in systolic blood pressure or diastolic pressure of over 120. Position the patient with head elevated, transport rapidly to the emergency department, and establish IV access, monitor blood pressure. So not much we can do for these patients, but to support their ABCs and take them in for definitive care. Another condition we can have is aortic dissecting aneurysm. So this is where you have a weakening section of the aorta and cause the aorta to dissect, or it can rupture. So you can have dissecting where it is there's a split in the separation of the inner layer, and so it's like you have two channels. So you have the main channel where blood is flowing, and there's another channel between the walls or the layers where blood is going to flow. Primary cause is uncontrolled hypertension, which is going to cause the walls of the aorta to weaken and give rise to this tear or separation. Signs and symptoms: sudden chest pain in anterior chest or back between the shoulder blades, but you can also have it in the abdominal area, so it can be abdominal aortic dissection, or it can be thoracic aortic dissection. So the pain can be abdominal also. Now we are looking at patient assessment for patients with cardiovascular emergencies, and we looked at emergency care generally, but with all patient assessment, it will be the same, except that you will have these unique cases where you have to tailor it based on the unique case. But patient assessment will always be patient assessment. You will start with your scene size up at all times. Never overlook scene size up. This is where you're going to decide if the scene is safe for you to enter into it. Are you prepared to enter into it? Can you manage what you are presented with in this scene? So you must do your scene size up. So, but with cardiovascular emergencies, we said that it is the survival chain. They need to get that early interventions. Those links in the chain must occur. So recognize a sense of urgency for reperfusion when the patient receives no relief with medication. So at the end of the day, our thought process is that there's so much I can do for these patients unseen, so I need to take them in, do what I have to do and take them in. But I will have to do my patient assessment, which begins with scene size up. Ensure the scene is safe for you first, your partner, patient, family member, bystanders. That's the order. And make sure you have addressed whatever need to be addressed, or call the persons who can, or you stay back until it is. Then you will look at the mechanism of injury, nature of illness. Again, with cardiovascular emergencies, it can be as a result of trauma. Trauma can be involved. Again, we say don't have a tunnel vision, don't overlook these subtle signs. Make sure you consider everything and do a proper assessment. Identify, after you have looked at your NOI and consider if you're thinking of spinal motion restriction, you're gonna look at take your standard precautions and look at number of patients, and also consider the need for additional resources. You're advanced personnel, there's so much you can do. If you think the case needs paramedic backup and it's available in your jurisdiction, then you must call for it. After you have done your scene size up, it's always going to be the focus, which is the primary survey or primary assessment. And the first thing you want to do is to always get a general impression of your patient. You're moving towards a patient, look at your patient. Patient seem to be stable or unstable, seem to be alert or not alert, seem to be breathing or not breathing, any sign of bleeding. These will clue you in as to the condition of your patient just from the outset, so you have that approach moving forward. Recognize immediately after that there are any life threats, you move towards a life threat. It's gonna be focusing on your A, B, C, D, E's, or if there's trauma and there's exsanguinating bleeding, X, A, B, C, D, E. You will always check for a level of consciousness with or without manual stabilization, and check for your patients. Move to your ABCs. It will be airway first. If no exsanguinating bleeding, you need to ensure that the patient have a patent airway. With cardiovascular emergencies, patient can be having varying level of consciousness. They can be unconscious, cannot control their airway. You will have to do so for them. Suction where needed. After the airway, you will move to breathing. Is the patient breathing? No. Is there a pulse? No. You will go to your CPR. And we are saying apply AED here, but as an advance, more than likely, if your jurisdiction covers it or protocol, you'll be using a cardiac monitor. So it would be to apply your cardiac monitor and set it to the mode for defibrillation. If the patient is breathing, then you need to assess whether they need ventilator assistance or supplemental oxygen. Provide whatever is needed to maintain that O2 saturation, 94 to 98%, and attach your monitor. You would get your entitled CO2 reading, capnography, and also you want to listen to lung sounds and move down to your circulation. Any bleeding you'd control, pulse check, skin check, need for sign of shock, manage, and also think about fluid resuscitation. And you will move to your prioritizing of your patient. At this point, you would have gotten GCS and need to do a rapid scan. If it's indicated, you do it, and you would need to decide if you're gonna stay and play or move your patient. Once they're having a cardiovascular emergency, you need to recognize that there's so much you can do, and you need to package your patient and move to get your patient off that scene where they can get the definitive care. But you will move to your secondary history taken and secondary. So assess for any major bleeding as you look at your primary survey, and substantial edema, determine the rate, quality, and degree of distress, respiration. Assess for crackers. We look at all of that and consider use of CPAP when needed. After assessing air and breathing, assess the patient's circulation, pulse, skin cap refill, make a transport decision based on whether the life threats have been stabilized. And even if you have control to a point, remember that doesn't mean that the patient is stable. You still consider that they are having a potential condition that need to be checked out, and you need to take them in. So after you have completed your primary survey, it's down to your history taking. Conscious patient, you need to get that history as quick as possible because they can deteriorate and valuable information can be missed. So you need to get that history of the chief complaint, factors surrounding it, OPQRST. You need to move to your sample history, which will give other information that can help you to understand better what's going on with your patient. But not only you, but will help your person you're handing over to better understand what's going on. So it's very important you get that history. And even an unconscious patient, don't tell yourself you cannot get any history. You can search a patient for any medical alert tag or bracelet or card, and also get history from file member bystanders. So you will determine and investigate the chief complaint and history of the present illness. A chief complaint of chest pain or discomfort, shortness of breath, or dizziness should be taken seriously. Determine whether the patient is experiencing chest pain or discomfort or any respiratory difficulty. So ask all the relevant questions that will give you the information you need based on the chief complaint and their sample history. Very important. Ask about other common signs and symptoms. Again, we say they're watchful for subtle signs and obtain the sample history, which will give you further information. Ask about medication allergies, and all of this information can help you in your treatment, and also will be information that the receiving party needs. Ask questions specific to cardiovascular and emergencies. Have you ever had a heart attack? How was it managed? How was it? How did it affect you? Do you have diabetes or any problems with your blood sugar? Again, we say you can have other conditions that will mimic these cardiovascular diseases, so be mindful of that. Do you have any risk factors for coronary artery disease, such as smoking, high blood pressure, or high stress lifestyle? This will predispose them to be having these cardiovascular diseases. Once you have completed your scene size up primary survey or assessment, your history taking, then you will move to your secondary assessment. And remember, depending on the resources that you have, personnel and scene, you can be doing secondary assessment with history taking. The team leader would be getting the histories, partner will be moving with the secondary assessment. So use your resources accordingly. You will first want to focus on the area of concern. We are dealing with cardiovascular emergency, and so you're going to be focused on the systems that are involved: respiratory system, the cardiovascular system. These two systems work together. So one is affected, the other one is impacted. So you're going to be focusing on those areas, getting your focused physical examination, or if the need is there for a full body assessment, physical assessment. Depending on the situation of your patient, you might not have time to even do a secondary assessment if you are focusing on the life threats in your primary survey, but proceed accordingly. Part of your secondary assessment, you will need to do your full set of vital signs, and you'll be using your monitoring devices. So at this stage, you would have gotten your cardiac monitor on board. You'll be getting your pulse oximetry. You will be getting entitled CO2 capnography reading. You'll be getting that ECG tracing, 12-lead ECG if time allow, and relaying these information. So you will evaluate the patient's circulation, examine the respiratory system for signs of inadequate ventilation. This is where you are focusing on, and reassess the level of consciousness, measure and record the patient's vital signs, and obtain blood pressure reading on both arms to compare for stroke or aortic aneurysm. And the last thing you'll be doing in your patient assessment is reassessment. So reassessment. You're not gonna be driving in that ambulance after you have completed your scene size up, your primary survey, history taken, and secondary. You'll be just driving along, waiting to reach the facility. You should be reassessing your patient, a stable patient, every 15 minutes, and unstable patient every 5 minutes. What are you going to reassess? You'll be basically going over all you have done for your patient before. You're going to be checking back on the patient's level of consciousness. You're going to be checking your ABCs, looking back at the chief complaint, checking back on the vital signs, checking on your interventions. Very critical. Whatever you had done for your patient, check back and see if they are still working. Any newly identified problems, address them. So it's all about reassessing. Provide prompt transport to the closest appropriate facility, and document your assessment of the patient. By this, you would have called into the receiving facility and tell them what you're coming in with, giving them all the information that you have. Time of each intervention, patient response to interventions. But at the end of the day, we said time is heart muscle, so that patient needs to be taken to where they can get that definitive reperfusion therapy if it's indicated. Now, as it relates to specific emergency medical care for patients when they are having chest pain or discomfort, and we say it can be ischemic or because of actual infarction, treatment begins with proper positioning. We said patient will tolerate position sitting up. Conscious patients, they're better off sitting up because they will be having oxygenation problem, breathing difficulty. We can, with congested heart failure left-sided, they will have fluid in the lungs, so they will feel better, more comfortable sitting up. Provide oxygen as needed and maintain O2 saturation at 94 to 98%. Patient who is in obvious respiratory distress may need breathing assistance. So ventilator assistance, we said that some will benefit from CPAP, continuous positive airway pressure, and again, if needs to advance airway based on the protocol, you will follow if your basic intervention is not working. Again, these patients might be hypotensive, so you will gain IV access. They might need medication, so it's always good to get that IV access in based on your protocol and provide fluid resuscitation if needed, maintaining that systolic blood pressure of over 90 millimeters of mercury systolic. And again, you must not delay transport. You need to recognize the need to get that patient who need to off that scene to definitive care. Depending on local protocol, prepare to administer aspirin and assist with nitroglycerin if there is no contraindications, and based on your protocol. Relieves pain of angina by increasing vessels to increase oxygenation to hypoxic tissue. That's what the aspirin, the nitroglycerin more so. The aspirin will prevent blood clots from developing further. So as it also dilates blood vessels in other parts of the body and can sometimes cause low blood pressure and or a severe headache. So even though we are trying to fix the problem in the heart with the nitroglycerin, it's gonna cause other areas to dilate, and that's why you have to make sure that they are over systolic blood pressure over 100 millimeters of mercury, and also they don't have any contraindications, sexual dysfunction medication, recent intake, which will cause their blood pressure to be already lowered. So administering nitroglycerin, you have to ensure that you have your standing order or online. You have to ensure that you check the 6 rights, check the condition of the medication, its expiry date, wear gloves when handling nitroglycerin, otherwise it can you can dose yourself with it. Obtain permission from medical control to administer prescribed nitroglycerin. Follow local protocol for administration of additional doses of nitroglycerin. Normally we say it's 3 doses per episode, and you would follow your protocol. Some patients have would have done heart surgery and they have cardiac assisted devices. Some patients will have pacemakers. You will observe that where you see a raised area on the upper part of their chest or their abdomen. Open heart surgeries are performed to bypass damaged segments of coronary artery. So they will do a grafting, take a blood vessel from another area to bypass the damaged coronary artery. Some patients will have implanted defibrillators. So coronary artery bypass graft, blood vessels from the chest or leg is soon directly from the aorta to a coronary artery. So it bypasses the damaged ear. And you can have percutaneous transluminal coronary angioplasty, which dilates the coronary artery. So they place a stent from a distal vein and into the heart, where it goes to the coronary artery that is blocked and dilated. Again, we say patients can have pacemakers, so their electrical conduction system is damaged, and so they are a pacemaker is inserted surgically, which will provide that stimulus impulse, electrical impulse to stimulate the heart. So inserted when the electrical conduction system of the heart is damaged, deliver an electrical impulse through wires that are in direct contact with the myocardium. Also, we say they can have automatic implantable cardiac defibrillators. So you would normally use an external automated external defibrillator, but this time they implant it, and so it is right inside there with them. Patients who survive cardiac arrest due to ventricular fibrillation have a small automatic implantable cardiac defibrillator, AICD, implanted, and this will give them the impulse when it is needed. It can be set to pace the ventricle or the both ventricle and atrium based on the condition or the damage to the heart. Or defibrillate according to the need if they go into arrest. For some patient will have external defibrillator vest with built-in monitoring electrodes and defibrillation pads. So it will monitor and it will defibrillate according to the need. Monitor provides alerts and voice prompt when it recognizes a dangerous rhythm and before a shock is delivered. And so you can have also left ventricular assist device used to enhance the pumping of the left ventricle in patients with severe heart failure. And you have several types are available. So all these are there to help patients who are having these problems with their heart, just to give them a adequate or sustain their life. Complete cardiac arrest, in which you have complete cessation of functional cardiac activity. So it can either be electrical, there's no electrical activity, or it can be electrical activities there. And as I said before, electrical activity does not always mean that there is mechanical activity. And also it can be that both have failed. No electrical activity, no mechanical activity. And indicated by absence of carotid pulse. So you have a group of rhythm that they are a condition called PEA, pulseless electrical activity. In this case, you have an organized rhythm, so there is electrical activity, but it results in no mechanical activities, hence no pulse is generated. This is also a lethal condition. Cardiac arrest, in basic case, you would have the AED, but as an advance, your protocol should cover you using a cardiac monitor. So in AED, automated external defibrillation, if portable, it can automatically administer an electrical shock to the heart when needed. So it's basically gonna stop the rhythm that the heart is in, which 4 rhythms the AED gonna pick up, which are the 4 lethal rhythms. Ventricular fibrillation, which we say will never give a pulse, and that's where it will one of the shockable rhythms. So it's gonna have 4 rhythms, 2 shockable, 2 non-shockable. The two shockable rhythms that the AED will pick up are ventricular fibrillation, which you say will never have a pulse, and also ventricular tachycardia. We say that ventricular tachycardia can have a pulse as well as not. So the one that the AED will pick up and as shockable is ventricular tachycardia without a pulse. The other two rhythms that are non-shockable are asystole, which you say is complete cessation of electrical activity, flatline, and also the one I just said, pulseless electrical activity. It's a lethal rhythm, no pulse is being generated, but asystole and PA are non-shockable, so the AED will not advise a shock. When you are using a cardiac monitor, it's your job now to interpret these rhythms. They will not, the cardiac monitor is not going to interpret it for you. You will see the rhythm and you will have to determine which rhythm it is and what you need to do with it. So you will have to know that is ventricular fibrillation. It's a shockable rhythm. You will set up the machine to defibrillate it. So you have to know what to do. Many use computer voice synthesizers to advise steps. So with the AED, it makes it easy for us, and that's why when you're a basic, you will use AED, but as an advanced, it's not going to be easy for you anymore. You're going to be able to do more when you can interpret the rhythm. So that's why it's that level you're at now. You should be able to do more for your patient, and you have done ACLS already, I imagine. So you would have known that there are different rhythms that you need to interpret, and it follows different algorithm, different treatment pathway that you will be able to assist your patient with out in the field once your protocol covers you. So AED, easy. It tells you what to do. It gives you the prompt. It analyzes the rhythm for you. It tells you what to do. All you need to do is follow the prompt. So AED comes equipped to give a monophasic shock or a biphasic shock. The older AED will use monophasic, where the signal is in one direction. So you'll have a larger energy dosage, which is 360 joules. For the newer machines, which is biphasic, you will have the energy going in two directions. So it will have a smaller dosage. Some will have from 120 to 200. That is what the AD would give as the biphasic dose, but that is automatically set by the machine, so you wouldn't know that. With the cardiac monitor now, you will have to set it to these ranges depending on your monitor that you're using. So you will always need to know your monitor, follow the manufacturer's instruction. Cardiac arrest for AED advantages. We said that before, the machine is gonna be fast to use, easy to use, because it's gonna interpret, analyze, and tell you what to do. And it's gonna deliver electrical shock for the patient in ventricular fibrillation or pulses vita. As I said before, you have some AED that is fully automated. With a fully automated AED, the machine will deliver the shock shortly after it advises you that a shock is needed or indicated. So you will have to know that you clear the patient, and then it will deliver it by itself. With this semi-automated, which is the most machine we have nowadays, it has a button for you to push to analyze, push to shock. So it will tell you that shock is indicated. You will have to clear the patient and then push the button to deliver the shock. Otherwise, no shock will be delivered with the semi-automated defibrillator. For its AED, it says it's going to be swiftly delivered, easy to operate, just follow the prompt, and intervention can be provided remotely. We have nowadays where AEDs can be delivered via, what do you call it, aerial drop. So this is the direction they are going now, where they can, you have a call for a situation where a person is suspected of having a cardiac arrest, they can deliver the AED to you either by dropping it directly or by at a point you just drop it from here. So are what we have depends on our jurisdiction, and it uses remote adhesive defibrillator pads. With the cardiac monitor, you will be using manual pads or manual pads which need charging, gelling up, and directly using them to deliver the shock. So again, know your monitor and follow your protocols. As I said at the beginning, you have 5 links in the chain of survival for an adult in suspected cardiac arrest. This is what is going to give them the best chance of survival from that arrest. And the first link is recognition of early warning signs and immediate activation of the emergency response system. And that is where, if there is possible that AD around in the area, this is where it's going to be helpful. Or we say if one can be delivered remotely, then that will be helpful. But it's that first link. If that first link doesn't occur or is delayed in occurring, then again, that outcome for that patient is going to diminish. Once that link is activated, then the second link would be immediate CPR with emphasis on high quality chest compression. So it's not just any old CPR. It has to be effective CPR. And we all know the components of effective high quality CPR. You need to have rapid defibrillation as the third link, because most of the time in the cardiac arrest case, the CPR is only going to buy some time, provide artificial ventilation and circulation until that person can get that defibrillation. Again, defibrillation might not work. The patient gonna need advanced care. So the layperson can provide that recognition and activation of your emergency system. They can provide that initial CPR high quality. They can provide defibrillation if an AED is unseen. But after that is gonna be needing the EMS system to come with basic and then advanced. And again, basic will come and can do so much to that point of defibrillation. Then it will be up to ACLS, where you're at as an advanced now, to provide that advanced care, which will come in with your advanced cardiac life support skills based on your protocol. And ALS and post-arrest care is what's gonna help that patient. If you are successful in getting them back to resuscitate them, then you'll be able to provide that care. Some of it can be done unseen, but ultimately the rest will have to be done and that definitive care in order to give them that maximum chance of surviving and also surviving without brain defects. So it's very important that you know this link in the chain of survival for the adult possibly in cardiac arrest. And there it's the diagram. It's an integrated link. It's as strong as its weakest link. Any chain is as strong as its weakest link. So if one link fails, the whole system fails. As we look at cardiac arrest, know how to work the AED into the CPR sequence. So as soon as the AED arrives, they should be used. Wherever you reach, you're gonna do your CPR until the AED is available, and you're not gonna stop CPR to attach the AED. You should be able to attach the pads while the person is doing their compression. It's designed for the pad to go right upper chest, mid clavicular, left mid axillary, so you can position the pads without stopping CPR. And also it's to be used as soon as it's positioned. You analyze, stop CPR and analyze as soon as it's ready, and follow the prompt, delivering the shock, clearing and delivering the shock if it's indicated. Error in use that we have with AED, most of the time is gonna be operator error. Failing to maintain that AED. You must check the AED comes with expiry date for the pads. It have expiry date for the battery. You have to check them. And also when you're using it, if you fail to use it properly, then you're gonna have error. If you're analyzing the patient while somebody's touching the patient, then you're setting yourself up to get a false reading. If you're delivering shock while somebody's touching, again, it might not kill the person who's touching, but it's gonna defer the charge that should go to the patient, and it won't be as effective. Emergency care for a person in cardiac arrest. Again, once they're in cardiac arrest, not breathing, unresponsive, no pulse, CPR is indicated. You're gonna do your compression, we said high quality, so it's gonna be pushed hard and fast, ensure the chest recoil. At 10 minutes minimum, maximum for an interruption, at least 2 inches deep for the adult, at least 100 to 120 compression per minute. Compression should not be interrupted unless absolutely necessary. Preparation for defibrillation. Do not defibrillate a patient in pool water. So they are submerging water, you have to get them out. If they are just lying on some water, you can do it. If they have chest is wet, you wipe it dry. If they have medication patches, remove them, wipe the ear. Shave hairy chest, and with this shave hairy chest, some protocol will tell you apply the pads to the hairy chest, and if the machine says check pad, you rip it off, you have a second set of pad, you put them on. That sounds crude, but it's all about time. When you are performing the defibrillation, prepare with standard precautions en route to the scene. Again, you should know your protocol before these situations occur. What will you do if you have to transport that patient? What will you do on scene? When will you move with that patient after doing CPR and AED use? So resume CPR immediately after defibrillation. Anytime you defibrillate, don't ask any question what next to do. It must be CPR next. When you are doing your mega code, as long as once you have initiated defibrillation, it's not to check pulse or set up IV access. Immediately you have to give that command, resume CPR, then you go to your next things. And if AD advises no shock and the patient has a pulse, check the patient's breathing. Gain IV access and initiate fluid therapy. Patient care after automated external defibrillation shocks. Follow your local protocols. So you are doing CPR and AED. At what point are you going to move with that patient? Some protocol will tell you after 6 to 9 consecutive shocks, then you need to move with that patient. Some protocol will say also the same protocol will also tell you that after 3 consecutive no shocks, then it's time to move with that patient. So you have to know the protocol before time, what you need to do when you're presented with these situations. You need a plan for treating the patient in the ambulance. And that's why we are saying that moving in the vehicle CPR is not going to be effective and can be dangerous. So you should have your plan. Protocol should guide you. And this is a diagram or an algorithm, a chart that shows how you should flow with the CPR AED use. This is stuff, basic stuff that you can look at and follow. Cardiac arrest. During transport, check on unresponsive patient's pulse every 30 seconds. If a pulse is not present, stop the vehicle, perform CPR until AED is ready, analyze the rhythm, and deliver 1 shock if indicated, and immediately resume CPR. Continue resuscitation according to local protocols. So once you have a conscious patient and they become unresponsive, then you need to ensure that you stop the vehicle. Once there's no pulse, you need to start your CPR, get your AD ready. As soon as it's ready, you use it. Clear, analyze, shock indicated, clear, deliver shock, and resume CPR. Again, follow your protocol. Cardiac arrest, if en route with an alert adult, patient having chest pain who becomes unresponsive, check for a pulse. If no pulse is present, follow the steps on the previous slide. Once you have return of spontaneous circulation, which is our goal if we are doing resuscitation, then we have to maximize the care of the patient to ensure that they don't go back into arrest. And these things are gonna include, first, you want to check if the patient is conscious or unconscious. If the patient is unconscious, then you might want to go to your advanced airway, taking care of their airway. You want to ensure that they have oxygenation 94 to 98%. You want to ensure that their entitled CO2 is between 35 to 45. So you have to have your monitor check their capnography reading. Again, you have time now to do your 12-lead ECG. You're going to check their blood pressure. You want to make sure that they have a systolic of 90 and above. And assess blood pressure, determine the patient can follow command. We have a thing that they call targeted temperature management for persons who are unconscious, they are in a state of coma. In order to preserve their brain, you want to reduce their metabolic rate, so you need to drop their temperature to below 32 to 36 degrees Celsius, and you need to get them to that range. So it's targeted temperature management. Normally that is achieved by giving them cold fluids. Again, you might not have that in the field, so you might not be able to do that for the patient. So again, it is manage what you can and move that patient to definitive care if you are in the field with them and you carry out that protocol and you had resuscitated them. Cardiac monitoring, again, we say as an advanced EMT, you will be using a cardiac monitor, and it have leads that you have to attach. To get monitoring tracing, you would connect 4 leads, and so just imagine you have the AD with white and red. Normally the white would go to the right upper chest, the red would go to the left mid clavicular. Well, you just move the white to the shoulder and the red to the lower torso, left torso. Then you'd have the black lead would go to the left upper torso or the shoulder, and the green which would go to the right lower torso. When you are going to get a 12-lead ECG now, then those leads would become more to the limb, so it go to the wrist for the white and black, and the red and green will go to the ankle corresponding legs. So place electrodes, attach the leads, obtain an ECG tracing prior to transport. So again, you need to know your monitor once you're working with a monitor. And we said for guiding principles, shave the electrode site, rub the electrode site with an alcohol swab, attach the electrode to the ECG cable before placement, and this is to ensure that you don't attach the electrode and then attaching the cable, which will put pressure, excessive pressure on the patient. So you attach the cable to the electrode and then attach it. When all electrodes are in place, and you will ensure that you have a better, it's properly connected also. When all electrodes are in place, switch on the monitor and print a sample rhythm strip, and you will see the connections for the, when you are doing a 12-lead ECG. So you're gonna have your 4 limb leads and your 6 precordial leads, we call them. So know the positions, V1 and V2 gonna be the 4th intercostal space on the side of the sternum. V1 will be on the right, V2 on the left. V3 will be exactly between V2 and V4, but V4 will be 5th intercostal space, mid clavicular. V5 will be same 5th intercostal space anterior, and also V6 will be same 5th intercostal space mid clavicular. And those are the positions. You will practice them in your class sessions. And that's the end of the cardiovascular emergency chapter. I will now take any questions. Any questions?